There is a small bottle that sits in millions of kitchen cabinets, usually beside calcium, magnesium, or a daily multivitamin. The label says vitamin D3. The front may promise stronger bones, healthier muscles, better immunity, or support for aging adults. One capsule contains 1,000 international units, another contains 5,000. Some bottles offer 10,000 in a single soft gel. Because vitamin D is sold without a prescription, the decision feels harmless. One pill is taken with breakfast, a calcium tablet containing more vitamin D is added at lunch. A one-a-day or Centrum multivitamin contributes another dose during winter. An extra capsule is added because there has not been much sunlight. No one calculates the total, then something changes. Thirst becomes difficult to satisfy. Trips to the bathroom increase. The stomach feels unsettled. Constipation appears. Muscles become weak. Thinking becomes slightly confused. A kidney stone attack sends the person to an emergency department, and the supplement intended to protect the bones is suddenly part of the investigation. The real warning is not that every adult over 60 should stop vitamin D. That would be medically wrong and potentially harmful. Vitamin D deficiency is real. Some older adults need supplementation because of inadequate intake, limited sun exposure, osteoporosis, malabsorption, kidney or liver disease, certain medications, or a documented deficiency. Current Endocrine Society guidance even suggests empiric vitamin D intake for generally healthy adults older than 75, while favoring daily lower doses over occasional high doses. What should stop is something much more specific. Taking high-dose vitamin D blindly, stacking several products without calculating the total, using enormous weekly or monthly doses as though they are safer than daily intake, and assuming that more vitamin D must mean stronger bones. That assumption has not held up in major clinical trials. Vitamin D helps the intestine absorb calcium and supports normal bone, muscle, nerve, and immune function. Adults through age 70 generally need about 600 international units per day, while adults 71 and older generally need about 800. Those recommended amounts include vitamin D obtained from food, fortified products, and supplements, not supplements alone. The problem begins when a nutrient requirement is transformed into a megadose competition. A person hears that low vitamin D is associated with osteoporosis, falls, weakness, heart disease, depression, infection, or cognitive decline. The conclusion appears logical. If low is bad, high must be protective. But nutrients do not always work that way. The body needs water. Yet excessive water can become dangerous. It needs potassium, yet too much can disturb the heart. It needs calcium, yet excessive calcium in the blood can injure the kidneys and alter electrical function. Vitamin D is fat-soluble. Unlike many water-soluble vitamins that can be eliminated more readily, vitamin D can accumulate. Excess supplemental intake can raise calcium absorption until blood and urine calcium become abnormally high. Severe toxicity can lead to nausea, vomiting, dehydration, excessive thirst, frequent urination, muscle weakness, confusion, kidney stones, kidney failure, abnormal heart rhythms, soft tissue calcification, and in extreme cases, death. The established tolerable upper intake level for most adults is 4,000 international units per day unless a clinician is deliberately using another dose for a specific medical reason. There are 3 supplement patterns that matter after 60. The first is ordinary, appropriate intake. A person receives vitamin D through food, a modest supplement, or a clinician-directed plan. The dose is chosen because of age, diet, medical history, bone health, or a known deficiency. Different products are reviewed so the total remains clear. The second is supplement stacking. A vitamin D capsule is taken beside a multivitamin, a calcium plus D product, fortified nutrition drinks, and perhaps cod liver oil. Each label appears reasonable alone. Together, they can produce a dose much larger than the person realizes. The third is bolus dosing. Instead of taking a small daily amount, the person takes a very large dose weekly, monthly, every few months, or once per year. The dose may have been prescribed appropriately to correct a deficiency, or it may have been copied from something found online. The danger is assuming that a massive dose taken less often is automatically safer or more effective. It may not be. A randomized trial involving more than 2,200 women aged 70 and older tested a single annual dose of 500,000 international units. The women receiving that enormous dose experienced more falls and more fractures than those receiving placebo, with the greatest increase in falls occurring during the first 3 months after the dose. That result seems backwards. Vitamin D is associated with bone health, yet a very large dose increased the events it was supposed to prevent. The exact biological explanation remains debated. A sudden rise may affect muscle function, balance, vitamin D metabolism, or activity in ways that do not occur with steady physiological intake. The larger lesson is clearer. Correcting a nutrient problem and overwhelming the body with that nutrient are not the same treatment. A separate randomized trial involving adults aged 70 and older who were already at elevated risk for falling compared daily vitamin D doses of 200, 1,000, 2,000, and 4,000 international units. Higher doses did not prevent falls, and some analyses raised safety concerns about serious falls and hospitalizations. This does not mean that 1,000 international units is dangerous for every adult. It means that increasing the dose did not automatically create better outcomes. Even among older people selected partly because their vitamin D levels were not high, the same pattern appears in fracture research. In the large VITAL trial, more than 25,000 generally healthy middle-aged and older adults received either 2,000 international units of vitamin D3 daily or placebo. Participants were not selected because they had osteoporosis or a confirmed deficiency. Over a median follow-up exceeding 5 years, vitamin D did not significantly reduce total, non-vertebral, or hip fractures. The trial did not prove that vitamin D is useless. It showed that giving a relatively high supplemental dose to generally healthy people who were not selected for deficiency did not provide the universal fracture protection many advertisements imply. A nutrient can be essential and still fail as a blanket treatment. So I want to tell you about a woman I will call Carol, a representative composite rather than one identifiable patient. Carol was 72 and had become intensely focused on protecting herself from a hip fracture. Her older sister had fallen in a bathroom and never fully regained independence. Carol decided she would do everything possible to prevent the same future. She began with a calcium supplement containing 800 international units of vitamin D. Several months later, a friend recommended a separate vitamin D3 soft gel containing 5,000 international units. Carol added it without removing the first product. Her multivitamin contained another 1,000. During winter, she watched a presentation claiming that older skin could no longer make enough vitamin D from sunlight. The presenter suggested that 10,000 international units was the amount many adults really needed. Carol replaced the 5,000 unit capsule with a 10,000 unit version made by a well-known supplement company. Her total daily intake now exceeded 11,000 international units. Carol did not consider this dangerous because nothing on the bottle felt like medicine. There was no pharmacist asking about kidney function. No computer warned about duplicate therapy. The product sat beside cereal and tea rather than IN's IDA prescription bag. For several months, nothing obvious happened. Then Carol began waking at night to urinate. She kept water beside the bed because her mouth felt constantly dry. She became constipated and lost interest in food. Her legs felt weak when she stood from a chair. The symptoms appeared gradually, so each received a separate explanation. The thirst came from dry indoor air. The urination came from age. The constipation came from diet. The weakness came from not exercising enough. Then her daughter noticed that Carol was repeating questions during a conversation. 2 days later, Carol became nauseated and unusually drowsy. She was taken for medical evaluation. Blood tests showed an elevated calcium level and worsening kidney function. Her medication and supplement list was reviewed, and the duplicate vitamin D products became impossible to miss. Carol was not diagnosed by the label on one bottle. Her clinicians still had to consider other causes of high calcium, including parathyroid disease, cancer, medications, dehydration, and other medical conditions. but the total supplemental dose, laboratory findings, and clinical history strongly implicated excessive vitamin D intake as an important contributor. She stopped the unnecessary products under medical supervision and received treatment appropriate to the severity of her hypercalcemia and dehydration. The thirst and confusion improved. Her kidney function was monitored carefully. The experience changed the way Carol looked at every supplement in the cabinet. She had believed she was taking 3 different bone products. Biologically, she had been taking the same active nutrient from 3 different bottles. What frightened her most was not that vitamin D could become toxic, it was that no single label had shown the dose she was actually taking. The correct dose existed only after all the labels were added together. Before I continue, let me ask you something important. Have you ever made a major decision while feeling worried, rushed, or unsure which information you could trust? And that is how costly mistakes often begin. A frightening headline can influence your investments. Conflicting health advice can leave you confused. A convincing salesperson, online scam, or emotional family situation can pressure you into acting before you have checked the facts. And after 50, the consequences can be much greater. One poor decision may affect your retirement savings, your health, your independence, or your peace of mind for years. That is why I want you to take a look at the decision trap. It is a practical guide designed to help adults over 50 recognize fear, manipulation, hidden bias, misleading information, and high-pressure tactics before making an important decision. Inside, you will find a simple step-by-step system for slowing the situation down, checking the evidence, asking the right questions, comparing your options, and protecting yourself from mistakes that could become expensive. Do not wait until a bad decision teaches you the lesson the hard way. Click the link in the description and get your copy of the Decision Trap now. Then come straight back because the next part gives you 4 specific questions for calculating your true vitamin D intake, checking whether the dose matches the reason you take it, and deciding when testing or medical review is actually necessary. There are 4 questions worth answering before continuing vitamin D after 60. The first is why you are taking it. Are you treating a laboratory-confirmed deficiency? Has a clinician recommended it because of osteoporosis, osteomalacia, malabsorption, bariatric surgery, kidney disease, liver disease, low calcium, limited dietary intake, or another specific risk? Or did you begin taking it because vitamin D is broadly advertised as good for aging? Those are not equivalent reasons. Healthy adults younger than 75 are generally advised to meet established dietary reference intakes rather than routinely taking higher amounts for disease prevention. For generally healthy adults older than 75, the Endocrine Society suggests empiric vitamin D intake because of possible mortality benefit, but the guidance still favors a lower daily approach rather than intermittent megadoses. The second question is how much you are really receiving. Read every label. Look for the words vitamin D, vitamin D2, ergocalciferol, vitamin D3, or cholecalciferol. Check calcium tablets, multivitamins, bone health products, fortified shakes, gummies, cod liver oil, and prescription preparations. Do not confuse micrograms with international units. 1 microgram of vitamin D equals 40 international units. A product listing 25 micrograms therefore contains 1,000 international units. Do not assume that 1 capsule equals 1 serving. Some labels define a serving as 2 or more pills, while concentrated liquids can deliver large amounts in a small number of drops. And the third question is how the dose is scheduled. A clinician may prescribe a high weekly dose for a limited period to correct documented deficiency. That plan is different from taking a high dose indefinitely without follow-up. For adults aged 50 and older who have a reason for vitamin D treatment, the Endocrine Society suggests daily lower dose therapy rather than non-daily, higher dose therapy. Do not convert a daily recommendation into a massive monthly dose simply because remembering 1 pill seems easier. The body may respond differently to a large spike than to steady intake. The fourth question is whether you need testing. Routine vitamin D screening is not recommended for every healthy adult. Current guidance notes that universal blood level targets tied to specific disease outcomes have not been established in clinical trials. But that does not mean testing is never useful. Testing may be appropriate when there are symptoms or conditions suggesting deficiency. Osteomalacia, osteoporosis, malabsorption, abnormal calcium, chronic kidney or liver disease, certain medications, or when a clinician is monitoring treatment. Testing may also be necessary when toxicity is suspected. The standard measurement is serum 2,5-hydroxyvitamin D, but it should be interpreted beside calcium, kidney function, medical history, dose, symptoms, and the reason the test was ordered. The useful phrase at an appointment is not, "Should I stop vitamin D because I am over 60?" It is more specific. I take these exact products at these doses on this schedule. What is my total daily vitamin D intake? Why do I need it? And is this dose appropriate for my age, kidney function, calcium level, bone health, and medical history? That question turns a familiar supplement into an actual treatment decision. Do not stop a prescribed vitamin D plan without speaking to the clinician who recommended it. Someone with true deficiency, osteoporosis, malabsorption, or another established indication may need supplementation and monitoring. Do not continue a high dose indefinitely because it was once prescribed for 8 weeks. Initial correction and long-term maintenance are not always the same dose. Do not take extra vitamin D to treat fatigue, joint pain, low mood, frequent infections, memory problems, or muscle weakness without evaluating other causes. Those symptoms are nonspecific and can come from anemia, thyroid disease, sleep disorders, medication effects, kidney disease, neurological problems, depression, or many other conditions. And do not assume that vitamin D alone prevents fractures. Strong bones depend on calcium and protein intake, resistance and weight-bearing activity, hormone status, balance, fall prevention, smoking avoidance, alcohol moderation, medication review, and treatment for osteoporosis when fracture risk warrants it. The U.S. Preventive Services Task Force found no net benefit from low-dose vitamin D and calcium supplementation for the primary preventio and of fractures in community-dwelling postmenopausal women, and found that combined supplementation increased kidney stone occurrence. That recommendation does not apply to people with diagnosed osteoporosis, vitamin D deficiency, previous fragility fractures, or other established indications. That final distinction is the one dramatic warnings usually erase. Advice for a healthy adult is not automatically appropriate for a person with osteoporosis. Advice for someone with confirmed deficiency is not automatically appropriate for someone whose level is already sufficient. Advice for a 78-year-old living indoors is not identical to advice for a healthy 62-year-old who receives vitamin D through food and regular outdoor activity. And advice about a steady daily dose cannot be replaced with a giant annual capsule simply because the arithmetic looks equivalent. Carol's mistake was not believing that vitamin D mattered. It does matter. Her mistake was believing that every additional capsule created additional protection. The bottles did not strengthen one another. They multiplied the dose. So do not throw away vitamin D simply because you are over 60. Stop treating it as a harmless substance that can be increased without limit. Stop stacking products without adding the numbers. Stop using high intermittent doses unless they are part of a deliberate medical plan. Stop assuming that a supplement preventing deficiency must also prevent every fracture, fall, infection, or chronic disease. Vitamin D can protect the person who needs it. It can fail to help someone who already has enough. And in excessive amounts, it can become the problem the person never thought a vitamin could cause. The safest question is not whether vitamin D is good or bad. It is whether the dose in your body matches the reason you are taking it. Before you leave, understand what is really at risk. The cost of this guide is small, but the cost of one rushed financial decision, one misleading health claim, one convincing scam, or one panic-driven reaction can be far greater. It can cost you money you spent years saving. It can cost you confidence in your own judgment. And in some cases, it can cost you your independence and peace of mind. The decision trap was created to help you recognize pressure, fear, hidden bias, and misleading information before they influence an important decision. You may not need this guide every day, but on the day you face a decision that could affect your savings, health, or future, not having a clear system may become far more expensive than getting one today. Click the link in the description and get your copy of The Decision Trap now, because the best time to protect yourself from a costly mistake is before you make it.